We looked at CDC recommendations for PrEP and PEP. We evaluated and managed drug-drug interactions. We looked at patients who experience intolerable adverse effects and how to manage them. And we educated the patients on importance of lifestyle modifications. Now, when indicated, let's recommend immunization to patients living with HIV. Generally speaking, the immune response in people living with HIV is significantly lower. Even when the patients are receiving ART, the CD4 T lymphocyte remains significantly lower compared to people who do not have HIV. Even the B cell activation will be impacted by HIV, and this is most likely due to the persistent inflammation. Even in patients who have undetectable viral load, this inflammation persists. And in general, recommendations for vaccinations are similar in HIV patients, with the exceptions of a few contraindications in HIV patients, especially with CD4 count less than 200, because they will be severely immunocompromised, especially when it comes to live vaccines. In general, the data for vaccine effectiveness in HIV is very low, which has led to under-vaccination in people living with HIV. So we need to do a better job of vaccinating HIV patients. Let's take a look at 2024 ACIP recommendations for immunization in adults. We're going to look at what's recommended in general for healthy persons without HIV, and then we're going to look at what's recommended for people living with HIV and consider them in two groups. One with AIDS, so CD4 less than 200 or less than 15% lymphocytes, or people without AIDS, CD4 greater than or equal to 200 or greater than or equal to 15%. So for the annual influenza vaccine, which is recommended for everyone, either recombinant or inactivated, that stands true for whether people have or living with HIV or not. However, with the live attenuated influenza vaccine, that's actually contraindicated when people with HIV. So that should not be used. And of course, for healthy persons without HIV, it is not preferred, but it can be considered in people between ages 2 to 50. For pneumococcal, again, for people before age of 65, routinely, it's not recommended to give a pneumococcal vaccine. Certain conditions qualify people to get the pneumococcal vaccine, which includes HIV. So, and it doesn't matter the severity of HIV. So that's one of the reasons for people to get pneumococcal vaccine prior to age 65. And of course, PCV is preferred. If PCV 15 is used, it should be followed by a dose of PPSV 23. Otherwise, if the patient received a dose of PCV 20 or 21, they are good. They do not need the PPSV 23. And for hepatitis A, any person who is not fully vaccinated and requests vaccination should be receiving it, but otherwise it's not routinely recommended for healthy persons. However, it is recommended for certain situations, including HIV, and the severity doesn't matter. So people living with HIV should receive hepatitis A vaccination. Other qualifying conditions includes MSM, drug use, and this drug use is either injection or non-injection drug use. People with chronic liver disease such as cirrhosis, people who are homeless, and these are the common ones. There are other conditions that can qualify, for example, traveling to areas with a high risk of hepatitis, for example. For hepatitis B, it is routinely recommended in healthy persons up to age 59 to complete their routine vaccination for hepatitis B. Outside of that, there are situations that qualify people for getting Hep B. That includes HIV, Hep C, and people who inject drug, liver disease, sexual risk, and men having sex with men. For Tdap or Td, routinely everybody needs to get it every 10 years, and that's the same for HIV. For meningococcal, there are 5 serotypes that are circulating in the US, so A, B, C, W, and Y. A, C, W, and Y is the one that's more likely to infect or affect people living with HIV. So while these meningococcal are not routinely recommended in healthy individuals, the ACWY is recommended for people who live with HIV. Men-B, so serotype B is not necessarily a common one in people living with HIV, so it's not routinely recommended in HIV, but other conditions such as asplenia or complement deficiency will require this. And there is a new formulation on the market that includes all 5 serotypes at the same time in the same shot. So adults may receive a single dose of Pembrya, which is the brand name for this new formulation, as an alternative to separate administration of men ACWY and men B, when both vaccines would be given to in the same clinic day. For HPV, it is routinely recommended up to age 26. Beyond age 26, up to age 45, it is a shared decision making, and that's regardless of HIV status. Varicella vaccine is a live vaccine, so it is contraindicated in AIDS, so in advanced immunodeficiency, people who are immunocompromised should not be receiving live vaccines. So varicella vaccine is contraindicated. Otherwise, people, if they qualify, they may receive varicella vaccine. For recombinant zoster vaccine, which we have Shingrix. Shingrix is not a live vaccine, so HIV status, is not important. Everybody aged 50 and older should receive Shingrix shots, regardless of HIV status. And most recently, we have RSV vaccines available for the very first time. So these are recommended for anybody aged 75 or older. Those are the most at risk for getting hospitalized, and that's regardless of HIV status. For age 60 to 74 years, if those patients are at increased risk of severe RSV based on comorbidities and compromise, those patients may also receive RSV vaccines. We also have a Mpox vaccine, Jynneos, and any person at risk for Mpox infection, regardless of HIV status, should receive Mpox. And essentially, these are persons who are gay, bisexual, and other men having sex with men, transgender or non-binary people who in the past 6 months have had either a new diagnosis of at least one sexually transmitted infection, or more than one sex partner, or sex at a commercial sex venue, or sex in association with a large public event in a geographic area where Mpox transmission is occurring. Those qualify patients to get Mpox, and that includes healthcare providers if they are at risk. Now here is a summary of recommendations for pneumococcal vaccines prior to age 65. So we can see that certain conditions qualify people to get pneumococcal vaccine, and HIV, of course, as mentioned, is one of the conditions where people will need to get either PCV 15, 20, or 21 prior to age 65. And if they got PCV 20 or 21, there is no need for a follow-up PPSV 23. But if there is PCV 15, there needs to be a PPSV 23 at least 1 year after PCV 15. If for some reason they had already received PPSV 23 and now they need to get their PCV, there needs to be at least 1 year apart. Now here are the recommendations for the 2024-2025 COVID vaccines, which were actually updated in October of 2024. So in general, all persons aged 6 months and older should receive the updated annual COVID vaccine. And so essentially most people will be fully vaccinated, so they essentially need a single shot. in case you come across people who are unvaccinated, again, one shot is recommended unless it's Novavax. For Novavax, they need to get 2 shots that are 3 to 8 weeks apart. But otherwise, everybody gets 1 shot. Except for 2 groups of people who are at increased risk, so they may get additional doses. So the first group is persons aged 65 years and older, and this is the new recommendation that came from the October 2024 meeting from ACIP. So now they recommend for age 65 and older 2 doses of the vaccine that needs to be 6 months apart. And in case that 6 months cannot exactly be arranged, at minimum it needs to be 2 months apart. The second group is immunocompromised patients. So that includes people living with HIV, and they should receive at least 2 doses. So again, this should be 6 months apart with a minimum of 2 months interval. And it says at least, so based on clinical judgment, based on shared decision making, and based on severity of immunosuppression, patients may actually get additional. And it's important that every additional dose should be at least 2 months after the previous dose. This concludes this presentation.